we're back after a break, so well done for coming back promptly, hopefully online as well as in person. Just a little update, because obviously we're juggling, not literally, Zoom and in person. And I think that the way the microphone is working is the microphone at the front here picks things up best. So what we're going to do, if you can bear with us, because it's really important for everyone who's online to be able to hear the questions too, is that even if there's a question at the back of the room, between Karim and I, we're going to stand at the front and repeat the question just to make sure everybody who's online can actually hear what's going on. So just bear with us, that's what we're doing, just to make sure that the audience online can hear too. And then I'm just going to introduce then the chairs for the second session, Dr. Valencia.
My name is Michele Mantega, one of the ST4s in Indian Hospital, and I would like to thank first of all Professor Mira and Professor Martin for this opportunity to present an interesting case that puzzled our team at UCLH about 10 kilograms in the last 2 months, leading to a weight of 102 kilograms and a BMI of 39. His past medical history included OSA, hypertension, type 2 diabetes. It was diagnosed 2 to 3 years before and was worsening recently. His drug history included empagliflozin, trulicity, duloxetine, perindromycin, doxazosin, Lantus 30 units per day, and atorvastatin. And when he was seen in clinic in December 22, on examination, he appeared Cushingoid with apnea, and his blood pressure was 123/83. His initial investigation in Malta showed a 9 cortisol of over 1,000 with the upper limit of 619. He failed to suppress on 2 different occasions on overnight dexamethasone suppression test, one occasion on 746, in the other one over 300. His 24-hour urinary free cortisol was also elevated, over 1,000 in one occasion and over 860 in another one, with the upper limit of normal 806. His ACTH was within the normal limits, however, this was on the higher side of normal, and he also failed to suppress on a low dose dexamethasone suppression test, with a cortisol level of over 233. His HbA1c was also elevated, with a level of 79 milligrams per mole, and his sodium and potassium were normal, 140 and 4.4. The rest of his pituitary, renal, and liver profiles were within the normal limits. So the team in Malta proceeded to arrange for him for a pituitary MRI. They showed a 5 × 3 millimeter hypointense microadenoma. So he was referred to our trust for consideration of surgery, and at that point, as per protocol, we proceeded with a bilateral IPSS with CRH stimulation, and this was performed on the 31st of October, showing a level before CRH stimulation less than 2, with a peak at 1.12, and a level of less than 3 after 3 minutes, with a peak of 1.69. His ACTH rose to 217, which was more than 3 times the upper limit of normal. And looking at the literature, false negatives can occur between 3.5 and 5%, especially in younger patients. So at this point, the MDT, since the IPSS was inconclusive, decided to proceed with MRI pituitary, with looking for ectopic source. And we organized a CT chest, abdomen, pelvis, and a gallium 68.8 PET MR. And the CT showed bilateral adrenal nodules. However, these were quite small, 1.2 centimeters on the right and 1 centimeter on the left, and benign in appearances with Alpha units -3. These were discussed in our adrenal MDT, and no further imaging were required for these nodules. And these were visible on the PET MR, however, not clearly traced avid, and no other lesions were seen in small bowel, pancreas, and lungs. And there was physiological uptake to the pituitary gland. Since the patient was actually deteriorating in our ward with worsening proximal myopathy, he became almost bedbound, and his diabetes also was difficult to control. And we did have some evidence of response to a CRH stimulation, and no evidence of ectopic source. The team decided to proceed with transfemoral surgery. It was done on the 24th of November, and this was a straightforward surgery. The suspected microadenoma was seen immediately and removed. And after a few days, the histology came back showing a normal anterior pituitary gland. And no adenoma was identified on 3 levels of assessment. Regarding immunostaining, this showed mixed nuclear expression, especially for Pt1 and SF1. Regarding cytoplasmatic leveling, this showed mostly positive for growth hormone and moderate positive for ACTH and LH. Looking at his post-op cortisol, On day 1, this was 367, with reference range between 153 and 537. On day 2, 660. On day 5, 287. And we organized 2 overnight dexamethasone suppression tests, one on day 7 and one on day 11, showing not suppression, but some response compared to his previous workup phase when over 700 and over 300. And we organized also a post-pituitary MRI after a week. And this shows some tiny punctate foci of hyperenhancement in the left pituitary gland, but the discrete lesion was seen previously, was no longer conspicuous. So good outcome from surgical point of view. And since the patient was quite keen to return to Malta, was feeling better, for safety reasons, we prefer to discharge him on 10 and 5 milligrams of hydrocortisone. And he was seen in his clinic 2 months later after the transcranial surgery. And he was feeling much better. He was feeling more energetic, coping well with the ADLS, and he lost about 5 kilograms. It was having less food craving, so good clinical response as well. The team in Malta at that point proceeded with a check in cortisol that was 356 nanomole per liter. And we're planning to perform overnight dexamethasone suppression test and also aim to bring down his hydrocortisone. His HbA1c also improved to 64, was initially 79. His blood pressure remains similar to previous readings, 130/90. So in conclusion, I present a case of a 26-year-old gentleman with hypertension and type 2 diabetes, with both clinical and biochemical evidences of hypercortisolemia, a pituitary microadenoma, an equivocal IPSS, but negative histology, and also with small bilateral adrenal nodules. So the question for the discussions are, do you suggest any further investigation at this stage? What treatment option do you recommend moving forward? And what investigation do you suggest if the symptoms reoccur? Thank you.
Yeah, you can talk and do this. Okay, go ahead. Go on.
Thank you very much.
Doug. Yeah.
Thank you very much for this presentation. It's truly international.
Just press it once and then it'll go green.
You don't hold it.
It's on, I think.
It's just you have to, it's a little bit relaxed. It will take time. And then, And anyway, thank you very much for this truly international clinical challenge and very, very interesting. Do we have any comments? Anyone wants to comment?
So just to clarify, the MRI was positive, and intraoperatively, was there a tumor?
Yeah, they see it immediately, and they clear immediately.
The histology is negative,
But
and the patient got symptomatically better.
Yeah. So this,
Partially.
but yeah,
So
completely.
the
But
question is, what happened to that tumor, and why is it negative? I mean, you could go back to the histology and have a look. I mean, not to the
IPSS?
to the
IPSS, and maybe have a look at it.
Yeah.
And see why is it equivalent.
Did you have any prolactins?
Yeah.
So we don't do in UCLH. They don't do IPSS superactive. They just do that with bilateral cannulation and CTH. And it was the last vial actually of CRH available. So I think it would be interesting to see if it reoccur, if you got any IPSS result with desmopressin.
Can I just make it for a microphone? I'll just so a suggestion in that this might be ectopic ACTH. And I say that because the left and right are exactly the same. Yeah, 3620, then it goes 127, 18. Yeah, they go symmetrically, where pituitary lesions tend to be on one side or the other, and they're not perfectly cannulated. So let's presume this patient's got a lung carcinoid tumor. Okay, then when you inject the CRH, it will travel up into the heart and then to the lung, where it will release the ACTH. And the ACTH will then travel from the heart to the aorta, where it will hit the pituitary first. So you'll pick it up there, and it goes down the patient's legs, and then back up the IVC, when you will then pick it up in the periphery. So that would you see how the periphery's gone 30, 70, and it's late because it takes a long time for the blood to go around to the feet and back up the IVC. And so it might be worth thinking about a gallium.
Why does the patient get better after the operation?
That's a good question. Well, okay, that's a bit of a challenge. We're not sure why they got better. It's a good question. Okay, can I suggest there's also cyclical ectopic ACTH. Okay. Yeah, you've got a gallium.
Yeah, we did a gallium, and there was no ectopic source found. They thought they were seeing the adrenal nodules, but they were not really uptaken.
Okay. It's just that IPSS, because we've got one other patient similar to this who turned out to have an ectopic lesion which has been removed, and it's just the symmetry of that pituitary and the timing and the rise late make it possible. Or is there any other imaging that we could try?
I mean, there is still a small, you mentioned on the post-op MRI.
Post-op, there's some residual. There's some
remaining.
residual.
So maybe we can, what about this famous methionine?
Well, that's pituitary.
Yeah, for pituitary.
So if we
there's
think
still something remaining which could suggest that perhaps not everything was taken up.
I think the fundamental thing, and Corinne's made a good point, we're very clear what ACTH-dependent Cushing's, but actually, which of the two diagnoses I'm still not clear about? Could this be ectopic ACTH versus Cushing's disease? And the IPSS, as you mentioned, isn't perfect. There's not a perfect diagnostic accuracy to any of our tests there. So is this an ectopic source which wasn't evident on the first galleon and maybe with time could have been evident, apart from, I accept that clinically he wasn't very well, was he? So maybe he was pushed to do something, but that would be where I would be wondering about where we were going.
And he had no medical treatment. He had metarapone at any point.
No. Because he came essentially, they referred directly for surgery, and we started with IPSS.
And the point about metarapone, Corinne, would be to try and buy some time clinically for something to become more evident on a galleon over time, if you think there's an ectopic source you're not picking up. Yeah.
And make him medically better.
Yeah.
Yeah.
Oh, I've got a question at the back, so let me just run up.
Okay, I'm going to repeat the question for the Zoom people here.
Now, Corinne, if you could get ready to repeat this.
I'm ready to go, yeah.
I'll have to be a bit more succinct than usual if you're going to repeat. I guess the point I wanted to make was that we've not proven that this man is cured of his Cushing's. We've also not proven that he has pituitary Cushing's. I completely agree with Karen's points earlier. It's a completely open question. So I guess my question really was about blockade. If you wanted a neat way of blocking the patient, you could use spaceriatide, which should only work on the pituitary, really, and shouldn't work on ectopic. Well, actually, that's maybe not completely true. Okay, so, but spaceriatide, I was wondering whether it would be selective for a pituitary source. But I think this patient is probably going to not be cured, going to require medical management, and will end up with a bilateral adrenalectomy. I wonder whether you want to comment on that.
Thank you, Ben.
I don't need to repeat because that was picked up by the microphone.
Perfect. Well done, Ben. It was picked up. I don't know if it's just the technical picture of the microphone or not. What are our thoughts about that? Do we think that he's heading towards a bilateral adrenalectomy? What are our thoughts about options for cortisol blockade?
It's quite young. I think it's 26, 27 now, but it's.
He's young to lose both his adrenals, you think? Yeah. Yeah. Okay, we definitely need a microphone for that question, Dr. Hatfield.
2 seconds. I think maybe the cortisol blockade question is further back, isn't it? Before we went for surgery, could we have decided to block him and wait for something to become more evident?
I was just interested, at no point he had medical treatment, is that right? And now, is he on anything?
So last time I spoke with Dr. Gupperta from Malta, they were trying to win him off the other cortisone and assessing of other cortisone.
Perfect. Okay, so you're going to start again, basically, and
See what happens.
Yeah, that is exactly in the chat. We know hydrocortisone.
Can I ask why he was on hydrocortisone? You haven't presented any evidence of cortisol deficiency.
They were concerned about him going back flying to Malta, and overnight dexametry suppression tests were better than before. So they thought it was some kind of response to the over 700 on the first time and over 300 on the first time. Post-op was 147 and 255. So not suppressed, but definitely less evident.
We wouldn't necessarily be keen on using an overnight DEX as an assessment that close to surgery, but I realise this is a patient that's travelling between countries and you're trying to.
So it was on day 7, one, and day 11, the other one.
I think that's difficult to interpret. So I think a general point is that patients post and treatment for Cushing's, they often feel terrible, even if because of the relative drop in cortisol. So there's often a management of that, but I think this is slightly different from that.
And I'd agree, Emma, that I think that I think you probably had attention, didn't you, you needed a patient to travel internationally. But I think Emma's point is very well made about the diagnostic accuracy of an overnight dex so close to surgery. I find that very difficult to interpret, I think. How about anyone on Zoom, Corinne?
Yeah, I'll just use this. Yeah, so it looks like they've had similar cases around the country, in fact, which turned out, I'll read this out, a tiny lesion in the lung, initial gamma tape was unhelpful and only confirmed with repeat imaging and reviewing by serial scans, cured by lobectomy. That's one example. A similar kind of IPSS picture. And we've seen 2 of these in the last 2 years, I think.
You can sometimes you have to wait for the evolution on the imaging of the ectopic source, don't you? I think that's the sort of point we're trying to make, that actually, I appreciate you had a negative gallium, but it may be that the alternative, and look, it's all about looking at what the options are, and the alternative could have been to manage him medically from a cortisol lowering point of view, and then re-image it a period of time and see whether or not you ended up with a positive or source of ectopic ACTH, essentially.
Yeah, like it's a medical treatment instead of adrenalectomy, gives some time, and then re-image to try and find that primary source. There's a question here about dex levels to check that he's absorbing the dexamethasone. I think that's a reasonable thought. And then there's the question about methionine PET to the pituitary a bit more carefully. Would that be helpful then? Can I ask about imaging using methionine post-operatively? This is for the surgeons, really. After you've poked around in the pituitary and changes.
Well, in this case, there wasn't clear allocated to the gland, but I think that's the point, as you say, the histology is negative even for another kind of tumor, so something was there. I think post-op methionine PET scans often difficult to interpret because you disturb the whole gland and you know what you get comfortable whether there's some sort of remnant of pituitary to one side, so it can be a bit more difficult than a virgin case.
And I think in terms of the question of methionine PET, in my head, if I think about the diagnostic pathway for this patient, I think methionine PET is helpful if you're trying to identify in more detail a pituitary target, but I haven't answered the question in my head, what is the etiology of this person's ACTH-dependent Cushing's? And I think that's what Ben was also saying. In my head, I'm still not clear, is this Cushing's disease or is this an ectopic source of ACTH? And so methionine PET isn't necessarily going to push me down. That's how I sort of break it down in my head.
So I thought there was another nodule remaining. That's what you mentioned on the side.
In the pituitary?
In pituitary, unless I completely missed it.
Just punctate foci, they said in the report. So just
I think there's any convincing tumor.
Yeah, I mean, we have a, I'm not going to jump ahead, but we have a, in our presentation, we did discussing in bureau, there was a post-op methionine PET, and it worked for us.
It did, and no spoiler alert, you're quite right. However, there was a bit more time, wasn't there? So you're quite right.
But I think we have time here to wait. That's the other thing. I think time will show, and I think time will show whether it's ectopic, time will show whether it's a very interesting case. I think maybe that's, if anybody has any other comments.
Okay, thank you.
I think everyone on Zoom agrees with that plan. Thank you.
So we will move on to the next. Thank you for this presentation. We'll go on to the next one, which is a case of recurrent Cushing's disease with unusual hematology from Dr. Jibalet.
Hello everyone, my name is Wafa from Royal Surrey Hospital. I'm going to present an interesting case of recurrent Cushing disease with unusual dermatomy. My patient is a 32-year-old female presented with weight gain mainly around the face, acne, extensive abdominal striae, proximal myopathy, supraclavicular fat pads, and skin chemosis. She had biochemistry done, which showed 24-hour urinary free cortisol of more than 1,000, with overnight dexamethasone suppression test with cortisol level more than 400. For that, she had 5-day cortisol profile done, which showed cortisol level remained around 400 for the first 3 days when we used the low dose dexamethasone. But when we used high dose dexamethasone, the cortisol level suppressed less than 30 with ACTH level of 7 on day 5. She also had pituitary imaging done, which showed probable adenoma on the left side, which then confirmed later when we did dynamic pituitary MRI. She also had MRI adrenal, which showed bulky adrenals, but there was no adenoma. The patient also had inferior petrosal sinus sampling done, which ruled out ectopic cause of ACTH. The patient then discussed in the pituitary MDT at Imperial and recommended to proceed to pituitary surgery for Cushing's. While she was awaiting the surgery, she developed itching, soreness, and pigmentation in vulval and perianal area. Therefore, she was seen by local gynecology and dermatology teams. She had colpovaginoscopy done, which showed widespread mixture of pigmented and slightly hyperkeratotic lesions. And she had biopsy done, which showed vulval intraepithelial neoplasia grade 3, which is high-grade intraepithelial neoplasia. For that, she was referred to specialist in genital neoplasia in the National Center at Homerton Hospital. Patient started on Mitrapone 500 milligram while she was awaiting the surgery, and she had transsphenoidal hypophysiectomy done in March 2021 with a histology result of corticotroph adenoma. Her postoperative cortisol level remained 36, and she was postoperatively discharged on prednisolone 5 milligram. After surgery, patient symptoms improved, including her anal symptoms, and she was therefore seen 8 months later after the surgery at Homerton Hospital, and she had anal smear done, which was positive for high-risk human papillomavirus, and the cells were mild to moderate abnormal. She also had a biopsy taken from perianal area and smear test, which showed anal intraepithelial neoplasia grade 2. She had excisional biopsy done of the anterior anal canal in May 2022, which was 1 year post her pituitary surgery. And she also had repeated vulval biopsy, which showed vulval intraepithelial neoplasia grade 1, and this time anal biopsy showed anal intraepithelial neoplasia grade 1, and no further treatment was required. December 2022, she experienced recurrence of her Cushing symptoms, including headache, worsening acne, weight gain, skin thinning, and proximal myopathy. This time, the biochemistry was mixed. She had overnight dexamethasone suppression test with cortisol level of around 109, and she had 2 borderline midnight salivary cortisol of 4.3 and 6.4, and she had 24-hour urinary free cortisol, which was normal at 143. Since March 2023, she developed and experienced recurrent symptoms of her vulval and perianal pain and itchiness again, coinciding with the recurrence of her Cushing symptoms. She was then re-reviewed by Homerton Genital Services, and she had repeated anal and cervical smear taken in December 2023. This time, cervical smear was negative for high-risk human papillomavirus. However, the anal smear was positive for high-risk human papillomavirus. And the anal canal biopsy showed anal intraepithelial neoplasia grade 1, which do not require treatment. She also had repeated MRI pituitary, which showed possible recurrence of the pituitary adenoma on the left side. And for surgical target and localization, she underwent methionine PET CT scan, which was done at Cambridge, and showed left-sided foci of the tracer uptake, which correlate with abnormalities I've seen earlier on the MRI pituitary. She had been restarted on Mitrapone while awaiting surgery, and then she had another transsphenoidal hypophysiectomy done in May 2024. and the histology result confirmed corticotroph adenoma. Patient currently in biochemical remission and her NS symptoms improved. Question for the audience: was the unusual anogenital infection and lesions triggered by Cushing's and the recurrence? Thank you. Happy to take questions.
Between cortisol level and the recurrence of this lesion, clearly there is something connected. I don't know much about the association with this intraepithelial neoplasia and the Cushing's disease. Is it known causes? Is it a known thing?
Well, you'd say it's a bit like HIV in terms of its immunosuppression, presumably. Is that the sort of concept about it in terms of why you get into HPV-driven region?
I think it is that, so obviously with this paper, actually.
Sorry, I should have
No, Wafa, please.
So, we said question,
The question.
No, is there a known relationship between this high cortisol level and the intraepithelial neoplasia? Is there a known thing? Or?
I couldn't find any relation between the high cortisol and
Sorry?
we also couldn't find any reported cases that with the Cushing and unusual isolations.
1987.
It's so interesting, and actually, Julian Walters at the back, and I'm looking at you because you had a really interesting case report. Do you remember a few years ago about PCP pneumonia in someone who was Cushing's ectopic? 2 seconds, I'm just going to come to you because it was actually, it was again this sort of sense of immunosuppression from high cortisol. Give me 2 seconds. Sorry, Julie, thank you.
Yeah, she had florid Cushing's and she was really quite unwell. And as soon as we started Pt2lateAMPituitary, she got really bad PCP and had to have an IT operation. So the immunosuppression of cortisol was the immunosuppression.
I could think so.
Keeping her PCP at bay. And as soon as we allowed her to reinstitute her immune response, she got a bad PCP. So yeah, and I actually had somebody, in fact, unfortunately, who died, who had Cushing's, really bad Cushing's syndrome and disease, and she had very bad asthma, and she started on some Pt2lateAMP and then developed really bad asthma and actually died of an asthma episode. So it's can be quite big in her case, but yeah. Thank you, Jeannie. So yes, that compromise is very interesting, isn't it? Corinne, have you got any? Could you check? Did everyone hear that on the chat? And are there any more questions on the chat?
Are there other questions on the chat? I think the sound was a little bit echoey,
So
but
the patient was looked after in the Royal Sarindar Hospital, so we've done a bit of reading at the time, because obviously we were not entirely sure whether that's related or not. So we thought maybe this HPV virus, because it's well known that obviously having Cushing's can reactivate some of the viruses. So I found some cases of hepatitis B or hepatitis C being reactivated also when patients were suffering from Cushing. So we thought this case would highlight to everyone the importance of thinking, for example, I would never think about patients like hepatitis B having Cushing's could reactivate it. And as it is actually described the immunosuppression from similar to HIV, because it's particularly affected the lymphocytes, the CD4 plus.
Well, very interesting. Emma, and whilst I'm coming to Emma, you discharged the patient, or the patient was discharged from us on 5 milligrams of prednisolone, and I wondered if you wanted to explain, because Emma had alluded to this previously on another case about, patients with Cushing's disease, often not feeling very well, even though you've got successful indicators of outcomes of surgery. Did you want to tell us your thoughts about why she was on 5 milligrams of prednisolone?
So the patient level on day 4 was 76, and the recommendation if it's less than 50 to start on prednisolone 6 milligrams. But this patient was found to be fast metabolizer of the prednisolone when we did the power level of the prednisolone, and the normal level should be between 15 and 25, and her level remained around 12. 8-hour level of the prednisolone. So therefore, she remained on the 500 milligrams of the prednisolone.
Thank you. And yes, just a typical dose for us
post-op would be 3 milligrams of prednisone, but often we give patients with Cushing's disease a slightly higher dose rather because they feel understandably quite rubbish as that cortisol comes down. Emma. Oh yes, just to follow up on that, actually often they need to go home on quite a lot more than would be physiological replacement just to get them used to coming down off that really big cortisol load that they have pre-op, otherwise they get lots of joint aches and pains and things. And I was just remembering that when I was equivalent of an F1 many years ago and I was on a respiratory ward, everyone who got high dose steroids got TB prophylaxis treatment as well. So in those days, presumably, I don't know if it's changed hugely now, but that was the fear was reactivation of TB from the steroids. But the point is that the yin and the yang, isn't there? So the steroid, the excess steroids is reactivating some infections. And I was thinking when we do high dose methylpred for Graves' ophthalmopathy or something, you have to screen for various virology things. But then the flip side is remember that quite often it's really dampening down that immune response. And that's, I remember the case Jeannie, I remember being the registrar and seeing this PCP on an X-ray meeting and being slightly alarmed. And that was, as soon as we treated her cortisol, of course, that flared up because in that setting, the steroid is helping you down your immune. That the rheumatology patients often flare up as you get their Cushing's out of control. So it's both sides you've got to think about. So presumably, just keep your antennae out for these things.
And also from a surgical perspective, surgeons, we do see some viral reactivation in patients who are undergoing surgery. The stressful and post-traumatic stress and maybe related to cortisol level as well. Especially for tumors of posterior fossa, posterior neuroma, when we operate, they get actually softer. And also for microvascular decompression, for neuralgia, they get a softer lesion reactivating. So there is some connection in terms of stress level and the viral reactivation.
I wondered if our presenter could come up on your presentation to the most recent pituitary MRI, and I'm going to bring Emma Lynn in, who's one of the neuroradiologists from our MDT, who's very kindly come after sleep deprived on call as well, just to talk to us about that contentious. You can come down here if you like.
No, this is the second.
The second,
This is the second.
This is the repeat MRI.
This is the second.
Of the recurrence.
Before the methionine PET, yes?
Yes, before the
So, for those in the room, there's this vocal, slightly ill-defined area of hyper-enhancement related to the lateral aspect of the sella turcica abutting the nerve cavernous sinus, slightly protruding into the suprasellar system. I think we're probably likely to be getting some of the bone structure posterior causing some artifact. But in my opinion, there is sort of a clear trauma contribution on that side.
Anything else on Zoom, Corinne?
No, there was somebody asking about whether AMIN1 had been ruled out.
How old was the patient? I can't remember.
She's young, but we have not.
Don't know the features of it. If there's no calcium problems or.
Anybody else, any questions? No, thank you very much. Thank you very much.
Thank you.
Thank you very much.
And if we can ask Dr. Moore from Kingston Hospital to talk to us about some imaging questions. So we will need Dr. Lim here. Could this be a pituitary stalk adenoma?
Hi, good afternoon, everyone. I'm Matt. I'm an IMC3 at Kingston Hospital, so please be kind. It's been thank you so much for having me. It's been a really interesting day as well. So I'm here to present a case that was seen quite recently in endocrinology clinic and has been discussed in our MDT as well. So it's a 27-year-old male who was referred from his GP in May of this year, and he was seen in clinic and reported several months of tiredness and low libido. He also reported an intermittent mild frontal headache. The main examination findings were bilateral painless gynecomastia, and he also reported some difficulty in losing weight despite exercise. He had no visual symptoms. He also reported no loss of smell, no polyuria, no changes in body hair, and there's no history of diabetes or hypertension. There's no history of testicular infection, trauma, or tumour. In terms of his past medical history, he had an episode of meningitis at age 14, but was on no regular medications, so there was no significant family history. He was a non-smoker, had social alcohol consumption and occasional recreational drug use. A few years ago, he used anabolic steroids for a period of 6 months, but no previous testosterone use. And his partner had an ectopic pregnancy about a year ago, and they were keen to start planning a family again soon. On review in clinic, his blood pressure was 139 over 82, he had a BMI of 37, he had bilateral gynecomastia and a normal visual field examination. So blood test results, the sort of main things that stood out, he had a low testosterone, very mildly raised prolactin, 437, and suppressed LH and FSH. He also had a slightly low IGF-1 as well. So we went on to do a few investigations. He had a normal ultrasound tested before this MRI pituitary was then performed, which has shown a well-defined mass about 2 centimeters in the suprasellar cistern, which was displacing the optic chiasm upwards and deviating the pituitary stalk to the right. A few more images as well. And so his case was then discussed in the skull-based MTT at St George's, and in part of the work I suggested a CT head to try and rule out meningioma at this time, which just shows the mass. And we also formally tested his visual fields, which didn't show any deficits. As mentioned in another case, we also performed OCT as well, and I've included some of the images for review, but essentially had a normal OCT. So there's no concerns about his visual fields and sort of optic compromise. We then performed an MRI brain pre and post contrast, and I just wanted to sort of show the optic chiasm as well there, which was unaffected. So during discussions in MDT, there's, as you can see, a bit of a broad differential list, and this is all quite recent. This was discussed about a month and a half ago, and today this gentleman still has an undiagnosed suprasellar tumour. I've sort of included a bit of a list of some of the things that were considered during discussions. I think pituitary stalk adenoma was quite high up the list, as well as a glioma. But would also appreciate any other thoughts or potential differentials. So part of our discussion was, given the fact, the size of the tumour and its location, resection was likely to result in this 27-year-old chap being pan-hypopituitary. And so the decision was made to spray him with repeat imaging in 3 months, which would be coming up this month. Given his plans to start a family soon, we were also considering options for fertility preserving gonadal replacement, and he was starting on tirzepatide for his weight management, and he's been referred here. So someone might be picking up soon in oncology clinic. So in summary, we had a young 27-year-old male who presented to clinic with a hypogonadotrophic hypogonadism, and was found to have this unusual suprasellar tumour. There remains some diagnostic challenges given to the location and appearance of the tumour. Although the pituitary stalk adenoma remains a possibility, it's probably difficult to have a formal diagnosis, as was discussed again in a previous case. Without having tissue, it's difficult to get a formal diagnosis, and also without invasive diagnostic or therapeutic intervention as well. So to date, this is a gentleman who's living with an undiagnosed tumour, which has been difficult to manage patient expectations as well, and will be followed up with interval scanning. I'm happy to take any questions, and I'll do my best, but it might have to be more of a discussion, I think. Thank you so much.
Thank you. I'd like to go on to the scan. If you could get back to the scan. I was looking for a differential diagnosis which you haven't included in your list. Is there the tumor or germinoma?
So on review of the case actually, I was having a look through that they've not tested pituitary or AFP, so I think that should be.
Given the proximity to the stalk, probably all stretched and wrapped around that tumor, there's no clinical features of vasopressin insufficiency, no?
No.
Yeah, and then one thing is, even though it's very low down the list, like possible meningioma as well, because unusual location.
Yeah, that's what I was looking for actually. Was there a post-contrast sagittal later on?
Meningioma, which is sort of a uniform enhancement.
Oh, yeah. That's you reminded me actually. That's what I was thinking at the time, because on this sagittal image here, I don't know. It looks like it may be potentially a little. It's touching there, and I was wondering whether there's a little tail. So yeah, completely forgot about that one. Yeah, what I was thinking at the time is that that's clearly an undifferential.
Meningioma would explain many things: the lack of all the symptoms, and it's slow growing, and will not cause any reaction around it. So it could sit perfectly there for years without causing problems. It's a difficult one to manage.
There's a question on the chat here that's asking about what about a biopsy?
So biopsy is possible, especially if I think the decision to give a period of monitoring is reasonable given the location of it, because this location is not an easy location to intervene from a surgical perspective. To go and to operate, you have to likely do a craniotomy or an endoscopic endonasal approach, which is slightly more extended approach than a standard pituitary operation. The pituitary gland and the sella is all clear, it's all normal. So if you have to traverse that to get to the tumor, obviously you have to disturb all the structures. And also for a craniotomy, it's a major undertaking to get to that tumor. So if we were to operate, we were to consider an option to intervene, we would rather go for debulking or excision as much as possible rather than a biopsy. So if you have to go there anyway, we would rather take it out.
Thank you. Okay,
there is a high risk that the surgery will almost more than 90% chance of having VI after the operation.
AVP.
AVP deficiency.
Oh, you changed the name again?
No.
But you did say DI, which is fair.
Yeah, I was thinking my temptation.
Well, I know, it's very difficult, but yes, we'll have to change the.
Well, we're doing better.
We're
doing better. We're not calling it.
I guess just, yes, a question at the back from Florian. If I run up, do you want to do one on Zoom?
I'll just for the, yeah, I'll just tell the summary of that little discussion was that surgery would not really be a good option because it had to be craniotomy rather than transphenoidal.
For a comment actually, or they may not be first on the list, but as Mr. Nair said, if we think about germ cell tumor, it's also important to do lumbar puncture, because the serum HCG may be normal, but it must be the lumbar puncture. Yes.
And also the whole spine MRI as well, just in case you want to do that.
And actually, I'm glad you said, Florian, because I was going to say the same. Oh, I'm so sorry. This week, sorry.
So that was a suggestion of a lumbar puncture.
Just two quick questions. I suppose looking at the radiology, is endocrine deficits are possibly a hypothalamic effect rather than a pituitary dysfunction per se. Just thinking about reasons why we should intervene. The gland is actually working well from what it looks like. And secondly, I was just intrigued, and this will be plugged into my talk as well. Did you say he has neural surgery surveillance and not endocrinology surveillance? So now sounds like neurosurgery is great, but just interesting.
So I think it's a skull-based NDT review as opposed to, it would be through the endocrine clinic though, so we'll be looking after them and repeating scans, but we discussed it at the NDT, yeah.
With regard to your first question about the hypothalamic involvement, this is on the floor of the hypothalamus, the floor of the third ventricle. It is sort of playing the chiasm either side, but it's not really into the third ventricle and damaging that nuclei around the hypothalamic structure. So I think it's unlikely that it's a hypothalamic involvement, but could be disturbing that axis.
I'm just going to pick on someone, is that all right for a minute? I just thought that I'm coming to object. I just thought, could we come back to you mentioned about him having a very high BMI. We've also got an issue in terms of testosterone, we have the SHBG. I wondered if it was just worth a comment on that for a minute. on what you thought about, we've got this testosterone, which is 2.2, SHBG, BMI is 34, did you say? And then the gonadotrophins will leave, if you leave that slide on that you
Sorry,
had.
yeah.
Perfect.
What was this sperm analysis? This sperm analysis.
I don't believe he's had sperm analysis.
Okay. I mean, one possibility is that he's got congenital hypertrophic hypogonadism that's been kind of alluded to with the hypothalamic effect, because it is very specific, isn't it? So, and do you know how big his testes size is?
Yeah, they were normal. So
Okay.
not off the top of my head, yeah.
Okay, so that would make congenital less likely. So, I mean, it could be, I mean, the pattern will be very similar if it's hypothalamic pituitary that's suppressed, but it is very severe in the gonadotrophins and the testosterone rather than anything else. So I think it's quite interesting. But his sperm analysis would also be worth doing if it's people refer to it. Because if he's got normal sized testes, then that's more against the congenital hypogonadotrophic pattern.
Him and his partner had successfully conceived previously.
Oh, okay.
She had an ectopic,
Okay.
sorry, yeah. They had
So-
successfully conceived. She had an ectopic pregnancy.
I mean, you can get reversal in 10% as well for congenital hypogonadotrophic hypogonadism patients as well. So, and depending on the genetic makeup, I think referred it to the panel that you can get. If you get TAC3 receptor mutations or TAC4 mutations, then those tend to be milder, but it's probably less likely in this case.
I just thought it was quite, as I say, quite profound and one axis, so I was just a bit interested in that bit. Just making sure I got this. Oh, hello, sorry, this way.
Is anybody else cynically thinking that he's maybe taking a bit more anabolic steroids more recently, given that one axis and that both his pituitary and his hypothalamus don't look massively involved?
So the argument against with the HB seems to be.
So just to make sure everyone understands that learning point, we were just saying that with true testosterone deficiency, it would affect hematopoiesis and actually end up with an anemia, which he's got, which makes it more likely to be a sort of true testosterone deficiency. That's my understanding of it. Yes.
Very happy to do
I think he's coming to your clinic, Audit. Yeah, andology.
Well, I might just bring Audit back up to that because I know we've got time, and I just wondered if you could, so you mentioned kisspeptin, just tell us how that'll be helpful.
Okay, so I don't know very much about kisspeptin. So you've obviously got the hypothalamus and the pituitary, generates at the top, but above generates kisspeptin, which is discovered in 2002 now or something. And so we've been working in the last 2 decades or so giving kisspeptin to patients of various sorts, but in this case, if you give a GnRH test, it's obviously testing the pituitary because the GnRH will act on the LH and FSH and increase. If you give kisspeptin, which we can do in a research setting, it will work on the GnRH to stimulate pituitary. The only downside is if his LH and FSH are very low, his pituitary is damaged, which it doesn't seem to be, then he might not respond. So going back to Anna's point earlier, where she was talking about, for example, differentiating patients with CTGP from CHH, that's one of the things that Maria, who's aware about it, is looking at them, is because we can test hypothalamic function for the first time, i.e., is their GnRH axis intact? You may be able to differentiate patients who've got hypothalamic dysfunction from pituitary. So your CGG patients who are late bloomers, for example, in puberty, will have a normal response to kisspeptin theoretically because their GnRH is intact. But the patients with CHH who've got GnRH deficiency, they won't respond to kisspeptin, so that's kind of what the test we're looking at there. But in this patient, we can easily bring them in and do a kisspeptin test, and essentially the results are anything more kind of for academic reasons, really, but I can tell you that there's hypothalamus intact.
Okay, we need a microphone, Dr. Hatfield.
Just coming in, sorry.
Sorry, just
a take home for this patient, I think, is that there are two active lesions that have been raised at this meeting that you might want to consider that you could probably do testing to eliminate, which both would have very different interventions. One was the germinoma, and that was tumour markers, serum and CSF. We've seen as Florian said, they're not always up. And the other was lymphoma, and I'm not clear how many screening tests you can do for that, but those both would obviously have very different pathways. So I thought that was helpful just for this patient. That's probably the top priority. Then obviously if it's not those, then you can breathe and think again.
This very interesting case and definitely very interesting discussion. And we welcome Dr. Agarwal for the last session. I understand the title changed, so I'm not going to say the title, but we all look forward to listening to this, to our last case actually before last case before lunch.
Hello, hi. Hi, this is Pallavi. I'm one of the registrars from Watford General Hospital, and I'll be joining ST4 training in Lewisham Hospital soon. These are the authors who contributed for this case, and they have done wonderful contributions. So the patient's overview, this is a patient who presented on 12th of February, a 67-year-old retired GP with progressive headache for about 3 months. It started in December. It was mainly in the left temple and right occipital area, worse with straining, coughing, and bending, and associated with nausea, vomiting, and positional improvement when she was upright. She also noted that her tongue was deviated to the left side, and she also had some mild swallowing difficulty, particularly to move her food from her mouth to the throat. Once it got to the throat, it was easy. She also had a history of 22-year-old history of facial paresthesia, but the tongue deviation and the swallowing difficulty was new. Since December, she also noticed some polyuria and polydipsia. The GP had done a HbA1c, which was normal. And she also noticed some hearing impairment in the left side compared to right, and difficulty concentrating visually, particularly on the phone. She had changed her glasses, but still was experiencing this symptom. Her past medical history included chronic fatigue syndrome, for which she was on amitriptyline and duloxetine, hypertension, for which she was on amlodipine and ramipril, and had a history of tubular breast carcinoma, for which she had underwent wide local excision in 2019 and was placed on tamoxifen. She was still on tamoxifen when she had come to us. And social history, non-smoker, just social alcohol and independent mobility and ADLS before coming to the hospital. So she was reviewed by neurology, and their impression was left 9th nerve and 10th and 12th cranial nerve palsy. This was mainly because her tongue was deviated to the left side and there was non-rising of the left soft palate. In terms of her limbs, her power, tone, sensation, reflexes, coordination, and speech were all normal. Her initial CT showed no abnormalities. She had also got a CT done by her GP 3 days before admission, and that was also unremarkable. We had done an MRA mainly to look at the vessels, so no hemorrhage, normal brain and cerebellum, and there was just some thickening in the maxillary sinus, and ENT review was recommended for query polyp. So the plan was to do an MRI brain with contrast and a lumbar puncture for cytology, culture, and to look at the opening pressure and to measure serum ACE level, quantiferon and Lyme serology and autoimmune screen. So this was her MRI. So MRI brain mainly showed hypophysitis. The differentials were either it was a metastatic process or inflammatory conditions like lymphocytic hypophysitis, IgG4 hypophysitis, lymphoma, or histiocytosis, Erdem-Chester disease. We had done a lumbar puncture, and she had normal CSF pressure, normal glucose and protein. There were no malignant cells in the cytology. The gram stain and culture were all negative, and negative for viral PCR. The quantiferon TB test and the Lyme study all were negative. She then had a CT cap because we were querying about metastasis. So the only finding was a 4 millimeter right lower lobe nodule, but no other abnormalities. She had some gallstones, but they were uncomplicated. CBD was 8.8 millimeter. In terms of her bloods, ACE level was normal, ANCA, ENA, and ANA were negative. ESR was 5. So she then got a bone scan done, and this showed focal uptake in the skull base, as you can see. Skull base and pituitary indicative of an infiltrative lesion, no widespread metastasis. You can also see something on the left wrist, but this was mainly the injection site. Her pituitary profile, so cortisol was slightly raised, natural in terms of stress response in the hospital. ACTH was preserved. TSH was also preserved, 1.3, and we could see hypogonadotrophic hypogonadism with low FSH, LH, estradiol levels. She was in the postmenopausal phase. Further endocrine findings, so in terms of polyuria and polydipsia, we did a strict input and output fluid balance, and we had noticed that the intake was around 4.5 liter and output 6.5 liters. So we had done a water deprivation test. So as you can see, the urine osmolality was 78, low, serum osmolality 293. Prior to desmopressin being given, and post desmopressin, you can see the readings here. The urine osmolality had increased to 600s. So the AVP deficiency, diabetes insipidus, was confirmed, and she was started on desmopressin. We also discussed with our weekly endocrine radiologist in the meeting, and his opinion was there was loss of high signal in the posterior pituitary area, and this could potentially cause diabetes insipidus. The pituitary stalk was bulky, irregular, and his opinion was metastasis is unlikely. There was marrow infiltration in the clivus and bilateral apex on MRI and CT, and sclerotic appearances on CT. And infiltration of extended up to the hypoglossal canal, and that explained the 12th nerve involvement. So we had taken different specialist opinions. She was in the endocrinology ward and regularly reviewed by the neurology team as well. Their opinion was this MRI is more in keeping with the malignant process rather than inflammatory, and their neuroradiology team agreed with this. We had spoken to her breast oncologist, and they had said that her breast cancer was a very low grade 1 breast cancer, ER positive, HER2 negative, and node negative. So it's unlikely a brain metastasis from her breast cancer. If it was a metastasis, it could be another, it could be from elsewhere or a primary itself. We had then spoken to the ENT team in view of the polyp, and they had examined and said that she mainly had a mild discharge, and she was, they had advised her to be on just sinus rinse drops. We had then spoken to the respiratory team in view of that 4 millimeter nodule, and they had advised that it's nothing significant, there's low probability of lung malignancy, and a CT chest in 1 year was arranged with nodule clinic follow-up. As soon as the MRI was back, we had referred to Queen Square surgery and neurosurgery and pituitary MDT, and their impression was there's a slightly bulky cellar and intracellular cellular tissue within with a heterogeneous enhancing tissue in the fossa and pituitary stalk, and there's clival enhancement, molding of the anterior visual pathway, and it's likely metastasis based on the imaging. So they had recommended some further tests like PET scan, serum IgG4 testing, and the pituitary profile, just the IGF and prolactin were pending from that time. Her desmopressin dosage was adjusted based on her output and sodium levels, and we had also focused on her symptom control with analgesia, antiemetics, and laxatives. She continued to feel a bit better and she was very much keen to go home, so we discharged her with some outpatient appointments on 28th of February. She then got readmitted in March with worsening symptoms. There was increased nausea, persistent headache on the left side, now knife-like, and it was 9 out of 10. Worse on coughing, bending, straining, and now tender to touch as well. She couldn't move her tongue to the left side. On examination, we noted 12th cranial nerve palsy with tongue deviated to the left. The visual fields were intact, fundus was normal, and there was no other neurological finding. By this time, she had her PET scan as an outpatient, and that had shown some increased uptake in the skull base, in the clivus, occipital, left sphenoid bone, with focal uptake in the pituitary fossa. Along with this, not only the skull base, there was also some fullness in the left tonsillar area of unknown etiology. So our plan was to give her some symptomatic relief with fluids, antiemetics, and analgesia, repeat her LP and update the pituitary team about the PET CT scan, adjust her desmopressin dose, refer to ENT for the tonsillar biopsy, and refer to palliative team for symptom control and gastroenterology team because she was having constant nausea and vomiting. So this was her PET scan. We then got some more specialist reviews. Pituitary MDT, their opinion was thickened heterogeneous pituitary stalk with skull base infiltration, and this made the biopsy very risky in the skull base. So they said that the tonsillar infiltration would be a safer target for biopsy, and the plan was repeat imaging in 4 to 6 weeks and consider pituitary biopsy only if there's no diagnosis by then. She was seen by the ENT team, and when they reviewed, they felt that particular area was just mainly a mild chronic tonsillitis. No masses were seen, and they planned to do tonsillectomy mainly to assist diagnosis, although they said that it wouldn't yield much information, just inflammation. We then referred to palliative care team, and she was started on a syringe driver with analgesia and antiemetics, and also started on some laxatives because the constant nausea and the headaches were making her life difficult. We also referred to the gastroenterology team who had done an OGD, which showed a mild gastritis, benign gastric polyps, MRCP, again, uncomplicated gallstones, so she was referred for outpatient cholecystectomy, and an NJ tube was placed for feeding purpose because she was only on fluids by this time, and her husband had reported that now she has lost almost 5 kilo weight in the last month, and she was also reviewed by the dietitian team. So we got our pending investigations back. So IGF-1 was normal 22, prolactin slightly raised 837. We also got the CSF flow cytometry from the repeat LP that we had done, and that showed no diagnostic immunotypic evidence for non-Hodgkin lymphoma. The IgG4 test, that also came as normal, 0.74, with the max range being 1.3. In this admission, she got further symptoms towards the end of March with some new hoarseness of voice, increased frequency of choking on water and struggling to swallow. The nausea and vomiting remained unchanged despite being on the syringe driver. She was not managing to keep anything down. She had some ongoing weakness and dizziness on exertion and difficulty mobilizing on her wheelchair. In February, she was someone who could walk independently, and now even on the wheelchair it was difficult. And she was having some headaches on and off. On 3rd of April, she had some new neurology as well. There was left-sided ptosis, right-sided facial droop in the upper motor neuron pattern with forehead sparing. The uvula was deviated towards the right, and the tongue, there was good movements throughout. and there was some reduced sensation in the right side of her oral mucosa, but the sensation on the face was okay. And she also had some weakness in the hip flexion, 4 out of 5, with intermittent loss of nasal visual field. So we have done some further imaging now based on the new neurology. So CT head, it showed bulky pituitary stalk, a pituitary stalk and a hypothalamus with bony sclerosis in the clivus, suggestive of hypophysitis. One particular day, she also became hypotensive. Her systolic was around 90. Her usual would be around 120. So we had retrospectively done a cortisol level for that day, and it was low 200. And she also had a low T4, 8.9, and hypoglycemic as well that day, around 3.1. So she was started on IV hydrocortisone, which was later switched to NJ entry, and also started on levothyroxine 50 microgram due to the low T4. She was reviewed by the ophthalmology team, and they said that there was no visual field effect. Her Bell's palsy had resolved. She then got an MRI done on the 6th of April, which showed interval increase in her suprasellar lesion with hypothalamic edema around, and the differentials remained as infiltrative hypophysitis, lymphoma, histiocytosis, or a malignant infiltration. We also discussed with our radiologist, and we agreed that there was large edematous pituitary stalk near the optic chiasm with sclerotic lesion in the clivus, and this could be a possible malignant infiltration. So this was her repeat MRI with some increase in size of the lesion. She was as soon as we got this MRI, she was referred to the pituitary MDT, and the neurosurgery and the skull base MDT, and we had vigorous discussions with the neurology team and the neurosurgical team, and it was finally decided that she should get an endoscopic transphenoidal biopsy because she had been waiting almost 2 weeks for the ENT tonsillectomy. And this was mainly delayed because of preoperative check, preoperative anesthetic assessment. So she had this transphenoidal biopsy done on 12th of April, and she was started on dexamethasone 8 milligram BD mainly because of the edema, and then transferred to Royal Free Hospital for neurology input. In Royal Free Hospital, she had some intermittent superficial left-sided headache. Her tongue strength had improved. She was unable to close her right eye fully, and her vision was generally okay, but occasionally flary patches and some minor visual field deficit in the left eye, inferior temporal area. She was also reviewed by the physiotherapy team and SOLVE team in Royal Free Hospital. Now, the turning point, we got the histopathology results from the biopsy, and we got the preliminary results on 19th of April, which showed some B-cell predominant histiocytic infiltration. But finally, in the lymphoma MDT, which happened on 26th of April, we got the final diagnosis that it's likely it is marginal zone lymphoma, and the plan was to start her on chemotherapy. So this was the histology report. So as you can see, there was some extensive chronic inflammation and unlikely to represent histiocytosis or IgG4 related disease. The infiltrate was predominantly B-cell, B lymphocyte phenotype with Ki67 proliferation index being high and suspicion of B-cell proliferative disease. So the final diagnosis was it was a skull-based marginal zone lymphoma, very localized, extranodal. Normally, marginal zone lymphomas are nodal or are in the lymph nodes, but this was an extranodal place. She had hypopituitarism, cranial nerve palsies 9 and 12, and the AVP deficiency, cranial diabetes insipidus. So the plan was for 6 chemo cycles. Our bendamustine was the treatment with hematology follow-up. She was converted from dexamethasone to the physiological dose of hydrocortisone and had some endocrine and urology follow-up in the clinic. So as you can see the timeline, it was 12th of February when she got first admitted, then discharged, and then readmitted in March, and then it was in April that we finally got the biopsy, and end of April when we got the diagnosis. So her follow-up in August, her hematologist had just told us that her repeat MRI after the 4 cycles of the 6 planned cycles of chemo shows very good partial remission. Clinically, she feels much better. She's no longer using her wheelchair or walking aids for the last 6 weeks. Her nocturia has resolved. There's only occasional mild headaches, and she also regained whatever weight she had lost. I think it might be particularly because of the hydrocortisone. She is having some tapering of her hydrocortisone because in the follow-up clinics we noted her cortisol was at the supra-physiological level around thousands. So at the moment she's on 5 and 2.5. It was just recently reduced in her clinic in August. She remains on tamoxifen, levothyroxine, lansoprazole, desmopressin 50 microgram BD sublingual, and some prophylactic medicines for chemo. And we also adjust her desmopressin based on her output and sodium levels. So she has some continued follow-ups arranged with us and hematology and neurology teams. So in conclusion, this was a rare presentation of marginal zone lymphoma causing hypophysitis, ABP deficiency, and cranial nerve palsies, and it involved multiple teams and the contribution of multiple teams, which made her feel better, and successful treatment with partial remission with chemotherapy. And I was trying to find the incidence, and I really couldn't find anything linked with marginal zone lymphoma itself, but I could find some articles with T-cell lymphoma and diffuse B-cell lymphoma, but since it's so rare, there's no exact incidence well established. Now some questions for discussion. So given the patient's clinical presentation and imaging, what would your top suspicion be for the underlying cause of the symptoms, and what are the potential challenges in managing this case?
Thank you. Really challenging and a complex case, and also you can imagine it must have been challenging for you to write all this up and present it in a structured manner. Very good. I mean, I was thinking more in terms of possible malignant deposit, probably from a primary cancer, breast cancer, and that all the cranial palsies and also in different locations would probably suggest that, but it's an unusual rare kind of. What do you think about the histology? I mean, not the radiology. Was it typical for a lymphoma? MRI could bring it back.
So I think, if we go to that last set of images, then both of those are fine. Then this sort of diffuse homogeneous enhancement is very, it does look very sort of primary CNS lymphoma. What I would say is, as Mr. saying, it's very unusual to get primary CNS lymphoma centered in the pituitary gland, and if it does occur, then it's usually non-Hodgkin diffuse large B-cell lymphoma, so a low-grade marginal zone lymphoma is very rare. I think reading about it, it's more likely to be located in the cavernous sinuses if it is going to occur in that region. Otherwise, it's typically more dura or parenchyma. So this is very unusual. You've never been able to guess this is marginal zone lymphoma. It's a very unusual appearance. I think
there's just one question on here about whether an infectious disease cause might have been considered, like a fungal infection. Is that?
Yeah, I mean, I think you can see from this point of view that the sphenoid sinus is clear. There's just a trace of mucosal thickening of that area. Yes, you can get infectious processes like TB, for example, but it doesn't look like there's any other supportive evidence of that. That would be unusual for that to occur primarily in this location. I think it seems that not that you've shown slides of this, but there are some clues along the way that diffuse involvement of the clivus without a sort of big nasopharyngeal mass or anything like that, because the cranial nerve palsies is highly suggestive of lymphoma, given the evolving cephalocytic findings as well. So I think there were some clues there alongside metastatic disease.
any other sites of that elsewhere. Yeah, so I think in conclusion, putting everything together became more clear that I think lymphoma wasn't emerging, marginal zone lymphoma wasn't emerging until the top of the differential diagnosis. I think, given the extensive bone involvement, for me, hyperphagocytis would be very likely. What your experiences?
Yeah, I mean, I think well, I have to say, in terms of, if you go back to the sagittal image, with the kind of hyperphagocytis we see in biopsy, normally they are bulky pituitary gland, bulky stalk, but it's more nodular, more solid, more like a tumor kind of lesion, but it's also uniformly intensely enhancing, which is more in keeping with the lymphomas process rather than standard ID4 or normally 4-5.
But one other.
Oh, yeah, I've got a few answers, so you go first.
Well, there's just, can I make a plea that we stop using diabetes insipidus, okay, as a diagnosis?
To be fair, you were very, I thought you were very good at it. It's a bit like HbA1c, Corinne, to have to move from percentage to millimoles per mole. I think it's about, you were very good at making sure you said the right terminology. So I think we just have to constantly remind ourselves, don't we?
Thank you. I
had a question for you, Corinne. Can you go back to your water deprivation test, if that's all right? Because in an earlier case, Professor Miller mentioned about the use of serum sodium, didn't you, as a useful, I guess, adjuvant to serum osmolality. And actually, I thought that was quite helpful. I wondered if you just wanted to talk, because not everyone's protocol has that, but you've done some work recently, haven't you? You can take mine.
Oh, thank you. Yeah, it's just to say that we have noticed that there's a slight variance on the osmolality that's wider than the sodium. The sodium quality control is much better than the freezing point suppression used by osmolality. So we have done them in parallel. Of course, you can calculate one from the other. So in this case, it's very neat and it fits very perfectly. But sometimes you'll find that the osmolality changes a bit more widely than it should, and therefore it can be difficult to diagnose. I mean, this is a nice clear case because the urine osmolality is really low. There's a good case. And the sodium climbs 140, 144, 148. So that's a very abnormal sodium. And it's much more, I think, to me, obvious that there's a diagnosis, a problem here than the osmolality, which has just reached 304.
That's perfect. I'm also impressed that you started a water deprivation test at 6 in the morning, which is a very surgical thing to be doing, but well done.
The patient did not want to starve for long, so she wanted to start early when she's in the sleepy phase.
So the patient drove it.
The patient drove it, but the NHS staff still had to be there, didn't they? So good for them. Okay, anything else on Zoom from anything in the room?
I just forgot to mention, whenever we had the first MRI, one of the radiology report had also commented if she was on any checkpoint inhibitors for her breast cancer in the past. Yes. So we asked that question to her, and she wasn't on any monoclonal antibodies or checkpoint inhibitors.
And the initial MR, you have that contrast MR, you would love to see that contrast MR you have. I don't think he had it.
Yeah. It's a good point about immune checkpoint inhibitors, isn't it? I mean, I think Canberra has just recently been licensed for breast cancer, but there are some case reports about positive pituitary involvement. It's very uncommon, isn't it? It's normally an anti-pituitary dysfunction that you'd see. I know there's multiple reports of that.
There's one more here on the chat, and that is the tonsillar biopsy. Would that have given us the answer more easily than taking the pituitary out?
Did it come out positive injury or not? The tonsillar biopsy, did you get it finally?
They did. Yeah. Oh, you got one. The tonsillar biopsy.
Oh no, we never got the tonsillar biopsy. No. We were just waiting on the date for.
It seems easier to get a pituitary biopsy than a tonsillar biopsy. That's what they've said in the chat as well.
Okay, so thank you to our chairs. That was a wonderful session before lunch. Thank you to all our wonderful speakers this morning. Lunch is served.